steps count as long as you're going forward. You add them all up and one day you will be surprised to see how far you have reached. So don't think and don't wait that the complete road will be clear. You will be able to see the end, how each and every step you're going to reach. Only then you will start your journey. Don't wait for that. That will never happen. So take a step. The moment you take a step, the next step lightens up. You take the step, the next step lightens up. And that is the way. So don't wait. Take the first step now. So with that, we start with the anatomy of the inner ear. Now, the anatomy of the inner ear, we have done already a lot of it in the embryology of the inner ear when we did initially. So what we are left with in the anatomy of the inner ear is the structure of organ of corti, structure of cristae and structure of maculae. So here, yes, this is, we know that organ of corti is present where? Yes, in the scala media. Scala media is how many turns? 2 3/4, 2.5 to 2 3/4 turns. Okay, now we know that above the scala media divides the bony labyrinth into a part above it and below it. What's the part above it known as? Yes, that is what is known as scala vestibuli, and the part below it is what is known as scala tympani. So here what we are seeing is the 2.5 turns of cochlea. This is the scala vestibuli and this is the scala tympani. In between is the scala media. So, the scala media is separated from the vestibuli above and the tympani below by membranes. So, let us take a cut section like this and see how it looks from inside. So, here we have taken a cut section of the bony labyrinth. So, what are we seeing here? Yes, this here is in between the scala media. Above it is scala vestibuli and below is the scala tympani. So the membrane that separates the scala media from the scala vestibuli above, this is what is known as Reissner's membrane. This is known as Reissner's membrane, and the membrane that separates the scala media from the scala tympani below, this membrane is what is known as basilar membrane. It's very simple to remember, it is in the base, it is below. So this is known as basilar membrane. On the basilar membrane is present the sensory end organ of hearing, which is known as organ of corti. And here in the scala media laterally, this here is the site of production of endolymph, which is known as a stria vascularis. It is known as stria vascularis. Now here in the stria vascularis are some channels present. They are the sodium potassium 2 chloride channels present. They are responsible for maintaining the electrochemical gradient of endolymph. So what at all is the electrochemical gradient of endolymph and where exactly is the endolymph? Yes, endolymph is present in the scala media, the fluid in the scala media. We know that the membranous labyrinth, here we are talking about the scala media. It has fluid inside it and it is bathing outside also in fluid. The fluid inside it is what is known as endolymph and the fluid outside where it bathes in, that is what is the perilymph. So here inside it is the endolymph, and endolymph has the electrochemical gradient of plus 85 millivolt. This is 85 millivolt and this is electrochemical gradient is maintained by the stria vascularis, the sodium potassium 2 chloride channels of stria vascularis. Now the moment I say sodium potassium 2 chloride channels, what comes to your mind is, yes, we have heard this somewhere. Where have you heard it? Where are these channels present, which you read very commonly? Yes, in the ascending loop of Henle. So, which means that we have these channels here also, in the ear also, which means if we are taking some drug, we are giving the patient some drug, which has to act on the sodium potassium 2 chloride channels in the loop of Henle, will it not act here also? Yes, it will act here also. The channels are the same. Do you know of which drugs act on the sodium potassium 2 chloride channels in the loop of Henle? Yes, they are known as the loop diuretic. Example, furosemide. So, will it not have an effect on the stria vascularis also? Yes, it will have. So, will furosemide be an autotoxic drug? Yes, it is autotoxic drug because it acts on the stria vascularis, the sodium potassium 2 chloride channels. Okay, and since the sodium potassium 2 chloride channels are responsible for production, which means whenever there is more of sodium, more of water, it will lead to more production of endolymph. Yes, so whenever there is more production of endolymph, we know, yes, that is a condition which is known as Meniere's. We ask the patient for salt restricted diet. Yes, so when it is our salt restricted diet and hypertension is not there, kidney disease is not there, and where it is given ear diseases, then you get confused in ear diseases what has sodium restricted diet to do. Yes, that is why we go for to decrease. Whenever we want to decrease the production of endolymph, we go for a salt restricted diet. And can you tell me the absorption of endolymph occurs from where? Yes, very good, excellent. It occurs from the endolymphatic sac. So the fluid which is present in the scala vestibula and the scala tympani, that is the perilymph. So we have the perilymph here. Now on the basilar membrane, we have the organ of Corti. So this thing that we are seeing is the organ of Corti. Now let us have an enlarged view of the organ of Corti. Yes, so this is how the organ of Corti looks like. We can see that in the organ of Corti we have hair cells. Yes, we have hair cells and supporting cells. The hair cells of the organ of Corti are divided into inner and outer hair cells, and we have multiple supporting cells which support the hair cells. So here we can see this here is the inner hair cell, and these three layers are the outer hair cells. Now the difference between the inner and outer hair cell is what we need to know. So what's the difference between the inner and outer hair cells? This is yes asked in your exams. Now inner hair cell is a single row of cell, whereas outer hair cell is arranged in 3 to 4 rows, which means suppose 3 to 4 rows, like in your classroom you have straight rows. Yes, so one row from front to behind, that is one row. One row is the inner hair cell, whereas outer hair cell is in 3 to 4 rows. So let us write the difference also. Yes, so let us write the difference between the inner and the outer hair cell. The inner hair cell is single row, and this is in 3 to 4 rows. Now can you tell me which will be more in number? More in number, obviously, what is 3 to 4 rows? This will be more in number. So this is more in number, this is less in number. Okay, now can you tell me what will be more prone to damage? More prone to damage, damage by what? Damage by noise trauma, damage by ototoxic drug. Which will be more prone? Yes, this is a very beautiful thing that God has made. What He has made less, that He has made more strong. He has made it more resistant. What is more in number, that is more prone to damage. What was less in number, if that becomes more prone to damage, that is already less in number. And if that gets damaged early, this is a very important sense organ of hearing. So that is why it's very simple to remember that what is more in number is more prone to damage. This is more prone. This is more prone to damage by noise as well as by drugs. Noise and ototoxic drugs. So let us see now. Okay, so what you are seeing here, this is a single row of inner hair cell, and here we have 3 rows of the outer hair cells. This we have the 3 rows of the outer hair cell. This is a single row of inner hair cell, and how the functioning of the inner hair cell occurs, what exactly is the role of the inner ear, let us see. Now when we say that what is the role of inner ear, it is responsible for transduction of sound. So how the transduction of sound occurs, how when the footprint of stapes moves, how the organ of Corti gets stimulated, just let us have a look. Now we know that when the footprint of stapes moves, what happens is that it sends vibrations in the perilymph of vestibule. We know oval window, OV. V of oval tells you it connects it to V of vestibule. From the vestibule, the sound goes to the scala vestibuli in one direction and opposite direction in the scala tympani, and the round window moves out. So this opposite movement creates a shearing action, and what is in between is the scala media. So because of this shearing action, there is movement of the basilar membrane. The organ of Corti is present on the basilar membrane, so this stimulates the organ of Corti. So as we can see in this picture, this is what we did when we did the anatomy of the inner ear also, that when the footplate moves, the vibrations go in this direction in the scala vestibuli, and then through the helicotrema in the reverse direction in scala tympana, and the round window moves out. So this stimulates the basilar membrane on which is present the organ of Corti. Now in the organ of Corti, we know we have multiple hair cells, and the hair cells are the tip of the hair cells project on a membrane that is what is known as a tectorial membrane. This is known as tectorial membrane. So if we have a look here, yes, we can see here the hair cells. The hair cells are arranged in the ascending order of their height, and the highest, which is the tallest, that is attached to the membrane above, which is known as tectorial membrane. Now when there is an opposite movement, what happens is the basilar membrane moves. So the basilar membrane will move, but the tectorial membrane does not move. Yes, so what happens when the tectorial membrane does not move? There is again a shearing action created. So now what happens in the hair cells? Just see, because of the movement of the basilar membrane and because of no movement of the tectorial membrane, now the hair cells are pushed in one direction. Because of that, what happens is, now here the hair cells, I told you, are arranged in the ascending order of their height. The tips of each of the hair cell is connected to the adjacent higher hair cell, and these tips are linked to some channels, which are the channels which open because of the shearing action, because of the movement. So these are known as mechanically induced channels which open because of mechanical shearing. So what happens is, because of the movement of the opposite movement of the tectorial membrane and the basilar membrane, the hair cells move. Because of the movement of the hair cells, now what happens is that these channels which are present on the tip of the hair cells, they open. Now when they open, here we have the endolymph. In the endolymph, we have more of potassium. So the potassium now enters into these hair cells. And now when this potassium enters into the hair cells, because of entering of the potassium, the voltage gated calcium channels open. So now that leads to entry of the calcium in the cells. Now when the calcium enters into the cell, now that leads to release of the neurotransmitter. So this neurotransmitter that is released here is what is glutamate. The excitatory neurotransmitter released here is glutamate, and yes, that was a question recently in your exam. What is the excitatory neurotransmitter of the inner hair cells? Yes, it is glutamate. Like everywhere in the CNS, it is glutamate. So these neurotransmitters are now picked up by the nerve, the cochlear nerve, which then transmit the signal to the auditory pathway and then to the auditory cortex. So this conversion of mechanical energy into electrical energy is what we call as transduction. So that is what is the function of the inner ear. Function of inner ear is transduction, conversion of mechanical sound energy to electrical impulses which are transmitted into the nerves. So now from the inner hair cells, when the transmitters are released, they are picked up by the nerve and they are transmitted through the nerve, which means that on the inner hair cells, we have the afferent nerves. So let us write this. On the inner hair cell, we have the afferent nerves. Whereas on the outer hair cells, we have the efferent nerves, which means that which is the hair cell which is responsible for actually transmitting the auditory signals? Yes, the inner hair cell. Whereas what does the outer hair cell do? Whatever response it gets from the brain, from the efferent nerves, it accordingly modulates the function of the inner hair cell. So the inner hair cell transmits auditory stimuli. Whereas the outer hair cell modulates the function. This modulates the function. Modulates inner hair cell function. Now what happens when the basilar membrane moves? First to move is the outer hair cells. So when the outer hair cells moves, the tectorial membrane moves along with that. Now when the outer hair cells move, they are much more in number than the inner hair cell. So first is the movement of outer hair cell, and because they're so much in number, their activity produces a sound which is loud enough for us to appreciate through the external auditory canal. So if we put a probe in the external auditory canal and we give a loud sound, so now what happens is the loud sound, when it moves into the inner ear, it produces the activity of the basilar membrane, activity of the hair cells, outer hair cells, and their activity produces a sound which travels back through the middle ear, and we can pick it up with the help of probe. So this is what is known as acoustic emission. Acoustic emission, a sound that we are hearing back because of activity of the outer hair cell. So this is known as autoacoustic emission. Auto, you can remember auto with O, so this is from the outer hair cells. So this is responsible for production of a sound which is known as autoacoustic emission. Autoacoustic emission. This is autoacoustic emission. So can you think of it that if we are recording back a sound, how is it going to help us? We are putting a probe and we are recording the sound of the outer hair cells activity. Yes, will it not tell us that the outer hair cells are normal? Will it not be indirect indication that the inner ear is normal? Yes, so will it not tell you that the inner ear is normal in this person? Yes. Also, since the outer hair cells are more prone to damage by noise, trauma, ototoxicity, so this sound that is we are recording back will be lost very early if there is noise, trauma and ototoxicity, much before any other changes appear which we can record. So that is why this is a very significant thing. This is very, very commonly asked in your exam. So now from the inner hair cells, the neurotransmitter glutamate is released, and now it is transmitted. The electrical impulses are transmitted through the nerve. Which nerve is that we are talking about? Yes, the cochlear nerve. Now the cochlear nerve first goes to the cochlear nerve ganglion. What is the name of the cochlear nerve ganglion? Yes, because the cochlear nerve also spirals around the modulus like the organ of Corti. So this ganglion of the cochlear nerve is also known as spiral ganglion. And now it moves out of the inner ear. Yes, it moves out of the inner ear. You will tell me if the nerve has to go out from the inner ear into the brain, it will go out through which foramen? Yes, very good, through the internal acoustic meatus. So after it has gone out of the internal acoustic meatus, what are the parts of the auditory pathway? Let us see that. So yes, from the cochlea starts the cochlear nerve, the eighth nerve. Now it has the ganglion. What's the name of this ganglion? This is known as spiral ganglion. Spiral ganglion. Now it goes out through the internal acoustic meatus, and now the rest of the auditory pathway mnemonic is SLIM. S-L-I-M. Now what is SLIM? Yes, from the internal acoustic meatus, it first goes to the cochlear nuclei which is present in the brainstem. So here we have the cochlear nuclei in the brainstem, and from here the rest of the auditory pathway, first is S, that is the superior complex. Next is L, that is the lateral lemniscus, and that is the double L. Next is inferior colliculus, and next is medial geniculate body. And ultimately then the sound reaches the auditory cortex area number 41, that is the superior temporal gyrus. Superior temporal gyrus, where the appreciation of sound occurs. Now, do we have to remember this complete pathway? Is it important to know each and every part of the pathway? Yes, that was a question that was asked in the AIMS, the sequence question. Put in the sequence, correct sequence, yes. So, we have the cochlear nerve, then we have the cochlear nuclei, and then SLIM, S-L-I-M. Now, again, has been a question that has been asked so much repeatedly. And what is that? There, we can test the complete pathway. The complete auditory pathway, starting from the cochlea, then cochlear nerve, cochlear nuclei, superior complex, lateral lemniscus, all this can be measured by a test, and that is what is known as BERA, B-E-R-A, brainstem evoked response audiometry. We are going to do this test in detail later on. But there, each and every part of the auditory pathway produces a wave. And the waves of the BERA are very commonly asked from you that what is wave 1, what is wave 2, what is wave 3. So for knowing that, we have to know, if we remember the sequence, we automatically know what the waves of BERA are. Now here, what are you seeing? That there are the auditory pathway, the nerves, they are going not only to the same auditory cortex, they are also crossing. Yes, so most of the fibers they cross, some also go to the same side. So the crossing occurs mainly at the level of superior complex, and that is the horizontal fibers of crossing, they are through the trapezoid body. So is trapezoid body involved in the auditory pathway? Yes, it is. It is the transverse connecting fibers of one auditory pathway to the other. Now, there are multiple interconnections not only in the auditory pathway of the two sides, because of which hearing, if we hear even from one ear, it is perceived from both the cerebral hemispheres. Along with these interconnections, there are some other interconnections also. Yes, so that interconnection you will tell me. Do you know of any interconnection from the eighth nerve, the auditory pathway, to any other nerve? Yes, we know that. Yes, to the facial nerve. What does that regulate? Very good, the stapedial reflex. Have we not done that? That whenever there is a loud sound, the auditory pathway senses that there is a very loud sound. It immediately sends vibration, the impulses to the facial nerve for the stapedius tendon to contract, stapedius muscle to contract for the acoustic reflex. Yes. So where does that happen? Where does that sensing that it is so loud that the facial nerve needs to get activated, that occurs at the superior olivary complex. So this superior olivary complex is a very, very important area of the auditory pathway for two reasons. First is that this is the center of stapedial reflex. Center for stapedial reflex. Center for stapedial reflex. And the second is that the superior olivary complex is the area from where localization of sound starts. The whole of the auditory pathway is responsible for localization of sound. Now, what does that mean, localization of sound? Okay, whenever you are sitting somewhere and there is suddenly a sound, do you come to know it is coming from your right side or from your left side? If you have 5 friends sitting in front of you and talking to you, do you know which one is speaking, or do you have to actually look whose mouth is moving, only then you come to know he is speaking? No, you automatically come to know. How do you come to know? Yes, because from whichever side the sound comes, it is louder in that particular ear. Second, it reaches that ear early as compared to the other ear. So this is what is known as localization of sound, to be able to locate that sound is coming from which direction. So that is a function of the auditory pathway, and this localization occurs in complete auditory pathway, but it starts at the superior olivary complex. So here the localization of sound starts. The localization of sound. Localization of sound starts. And what happens in the cortex, in the superior temporal gyrus? Here the appreciation of sound occurs. Appreciation. We hear a sound, unless and until it reaches the auditory cortex, we are not able to appreciate it, that what the person is speaking or there is some sound. Yes, so this is appreciation of sound. So this is what we need to know in the auditory pathway. So now, yes, keep down your pens. Yes, and quickly you are going to tell me which is more in number, inner hair cell or outer hair cell? Yes, very good. Outer hair cell. What is the electrochemical gradient of the endolymph? Yes, very good. Plus 85 millivolts. Now, can you tell me endolymph is absorbed from where? Endolymphatic sac. It is produced from where? Yes, it is produced from the stria vascularis. Stria vascularis is present in scala vestibula or scala tympani? In the scala media. So the endolymph is produced mainly from the stria vascularis, but the electrochemical gradient of the endolymph of the utricle and saccule, that is maintained by epithelium, which is similar to the stria vascularis. That is what is known as dark cells. That is known as dark cells. Why they are known as dark cells? Because they stain a little dark on histopathology than the rest of the cells there. So dark cells, they maintain the electrochemical gradient of endolymph in the utricle and saccule, The same function as stria vascularis, but stria vascularis has a more efficient function than the dark cells. What are the channels that are present in the stria vascularis? Yes, sodium potassium 2 chloride channel, which is affected by which drug? Name one drug which acts, which hence it can be autotoxic. Yes, very good. That is the furosemide. Okay, now what is the main function of the inner ear? Transduction. Yes. Now, can you tell me the complete auditory pathway? Tell me the complete auditory pathway. Slim. Okay. Is there nothing before it? It starts from the cochlea, from the cochlear nerve. It starts from the cochlear nerve. Yes. So yes, from the cochlear nerve. That is first. Second is cochlear nuclei. Then is third is SLIM. So pure livery complex. What is L? Lateral lemniscus. The double L of the auditory pathway is a very, very important part of Vera. What is that? We'll see that later on. Okay. What is I? Inferior colliculus. M is medial geniculate body. The localization of sound starts at superior livery complex. What is the center for stapedial reflex? Again, superior livery complex. And all these are questions that are asked in your exams. Now, similarly, we have the hair cells in the crystalline maculae also. What were the hair cells in the organ of Corti known as? Yes, in the organ of Corti, it was known as inner and outer hair cells. Whereas the hair cells in the crystalline maculae, they are not known as inner and outer hair cells. They are known as the type 1 and type 2 hair cells. So the type 1 and type 2 hair cells and inner and outer hair cells, is that very significant to know that there is a difference between the names of the hair cells? Yes. If it is said that this ototoxic drug acts on the type 1 and type 2 hair cell, can you tell me it will lead to hearing loss or it will lead to vertigo? In other words, if it is said that this ototoxic drug acts on the inner outer hair cell, will that be a cochleotoxic or a vestibulotoxic drug? Yes, so any drug that is cochleotoxic will act on the inner and outer hair cell. Any drug that is vestibulotoxic will act on the type 1 and type 2 hair cells. A cochleotoxic drug will result in hearing loss. A vestibulotoxic drug will result in imbalance. Yes, so here they are known as type 1 and type 2 hair cells. Now, in the cristae, where cristae present? C for cristae, C for canal, the semicircular canal. How many semicircular canals do we have? Yes, we have the 3, and they are responsible for what? Cristae is responsible for? Yes, rotational acceleration. So, in the cristae, the hair cells project into gelatinous matrix. This is known as cupula. Whereas in the maculae, the hair cells project into gelatinous matrix which is covered by calcium carbonate crystals which are known as otoconia, or they are known as otolith. Now, what is the significance of this otolith? Have you heard of rhinolith? Calcium deposition around foreign body of the nose is known as rhinolith. Yes. So, if there is a child who has come to you, who has with a complaint that he has put some stone in the ear, you will see the stone and you will write the diagnosis otolith. Yes or no? Is otolith the counterpart of rhinolith? No. What is otolith? It is a normal constituent. Normal calcium carbonate crystals which are present in the inner ear. In which part of inner ear? Yes, in the utricle and saccule, in the maculae. In the maculae, we have hair cells projecting into the gelatinous matrix which is covered by otolith. So, they are responsible for linear acceleration. So, now what happens? What can be the abnormality that can happen because of this otolith? Now, these otolith can get dislodged from their place. Where are they normally present? In the utricle and in the saccule. Okay. So, here we have the semicircular canals. Here we have the utricle and the saccule. So, otolith is present here attached to the maculae of the utricle and saccule. Now, if they get dislodged, now what will happen? They can get dislodged because of infections. They can get dislodged because of head injury. It can be idiopathic. Now, whatever the cause, it has got dislodged. They can get dislodged, and where can they go? They can go into the semicircular canal. So, when they go into the semicircular canal, they cause irritation of the semicircular canal. And whenever the semicircular canal, in which they have gone, that particular semicircular canal gets stimulated by a particular movement of the head, the otolith moves, irritates the semicircular canal, and patient has very severe vertigo. Now, these are calcium crystals, so they settle down because of gravity, and in a few seconds, the vertigo is fine, till the patient changes his posture of head again. And this vertigo, which results because of dislodgement of otolith, is what is known as, yes, because it occurs on change of position of head, it is known as positional vertigo, or it is known as BPPV. Benign, what is this? Benign paroxysmal, because it happens for a few second paroxysms, so it is paroxysmal positional, because it is because of change of position, so it is known as positional vertigo. We are going to do this in detail later on. So, this is what is BPPV, and yes, it is asked in your exam that in BPPV, because for the cause of BPPV, the most common semicircular canal to be stimulated is, in other words, the otolith go most commonly, they dislodge into which semicircular canal? Yes, the BPPV has the answer in its name, double P. So this is in posterior semicircular canal. So it most commonly goes in the posterior semicircular canal. And since BPPV is the single most common cause of vertigo, you can remember that posterior semicircular canal is supplied by singular nerve. This is just a way of remembering. You can remember it like that. Yes, so posterior semicircular canal, you can remember it is this BPPV is single most common cause of vertigo. Single most common cause of vertigo. So this is supplied by singular nerve. Posterior semicircular canal is supplied by singular nerve. Singular nerve, which is a branch of inferior vestibular nerve. Inferior vestibular nerve. So what do we know in the hair cells of the cristae and the maculae? Yes, where is the otolith present? Otolith is present in the maculae. And where is the cristae present? Yes, in the semicircular canal. If the otolith get dislodged, it can lead to which condition? Vertigo on position change. What is that known as? BPPV. BPPV is most commonly because of dislodgement in which semicircular canal? Posterior semicircular canal, which is supplied by singular nerve. Singular nerve is a branch of inferior vestibular nerve. Okay. So now both these nerves, the cochlear nerve, that is arising from the hair cells, taking the impulses from the hair cells, and from the cristae and maculae will be which nerve? The vestibular nerve. So both these nerves go out of the inner ear through the internal acoustic meatus. And where they go, the cochlear nerve we know in detail. The vestibular nerve, where it goes, that we'll do in detail when we do the vestibular physiology. For now, what we are seeing is that yes, both of them go out of the inner ear through the internal acoustic meatus. Yes. So how many nerves do we know of which pass through the internal acoustic meatus till now? Cochlear and vestibular. Okay. Now the vestibular nerve is not a single nerve. Vestibular nerve is two nerves, superior vestibular and inferior vestibular. So now how many nerves that you know of which pass through the internal acoustic meatus? Yes, cochlear, superior vestibular, inferior vestibular. Tell me one more. Yes, through the internal acoustic meatus, we know it is facial and the cochlear, vestibular cochlear. Yes. So we have the 7th and the 8th. So ultimately we have how many nerves passing through the internal acoustic meatus? 4 nerves. 4 nerves. Which 4 nerves? We have the 7th nerve, we have the 8th nerve. Now 8th nerve is cochlear, superior vestibular, inferior vestibular. Where is the internal acoustic meatus present? Do you remember that? Very good, internal acoustic meatus. Internal acoustic meatus, do you have a picture in your mind of the internal acoustic meatus? Yes, if you have seen that anatomy of the inner ear, you know where it is. The internal acoustic meatus, that is present on the posterior slant of the petrous part of temporal bone. Okay, so now let us see how the internal acoustic meatus looks like. So this here is the internal acoustic meatus. Now we have 4 nerves passing through it. Through this internal acoustic meatus is divided into 2 parts, a upper part and a lower part. And in the upper part is again divided into 2 parts by a vertical crest of bone. Now this horizontal crest of bone is known as the horizontal crest. The horizontal crest is known as transverse crest. This is not important for you to remember. But yes, this vertical crest of bone is something that you cannot afford to forget, and this is what is known as Bill's bar. This is known as Bill's bar. Now why is it so important to remember the Bill's bar? Let us see that. Yes. So what are the nerves that pass through it? Yes. So this is the anterior part. This is the posterior part. So we have the facial nerve. We have the facial nerve. That is the first. Yes. Okay. Facial nerve. Now also through the superior part will pass the nerve which has superior in its name, superior vestibular nerve. So then we have the superior vestibular nerve. And just below the facial we have the cochlear nerve. And below the superior vestibular, we have the inferior vestibular nerve. Along with the inferior vestibular nerve, we have the branch of inferior vestibular which supplies the posterior semicircular canal. Can you tell the name? Yes, the cingular nerve. So this is passing through a separate foramen, that is the cingular foramen. The cingular foramen, that is the cingular nerve. Now along with these nerves also enters the labyrinthine artery through the internal acoustic meatus, which is a branch of ICA. What is ICA? Anterior inferior cerebellar artery, which is responsible for supplying the arterial supply of the inner ear. Okay, now why is this Bliss bar important? This is a very, very important landmark for identifying all these 4 nerves. Okay, now suppose these are these 4 nerves. Okay, we have these 4 nerves, 2 above and 2 below. Okay, now I have to operate on the internal acoustic meatus. I have to operate on the facial nerve. How do I know which one is the facial nerve out of these 4? All the 4 are passing together through this small foramen. How do you know that which one is the facial? Yes, I know that facial is present in the superior part of the internal acoustic meatus, and it is present anteriorly. So, how do I know which one is the superior? Yes, the part which has the vertical crest. So, when I see the vertical crest, I know that this is the superior part, and the nerve that is anterior, that will be the facial nerve. Now, I want to operate on I want to do a vestibular neurectomy. I want to section the inferior vestibular nerve. So, how do I know where the inferior vestibular nerve is? Yes, how do I know where the inferior vestibular nerve is now? Yes, so I will first identify the superior vestibular nerve. I know that below the superior vestibular is the inferior vestibular nerve. So this is the superior vestibular nerve. Below that is the inferior vestibular nerve. So just by knowing the Bliss bar, I know which is the superior part, which are these 2 nerves, and cochlear will be below the facial, inferior vestibular will be below the superior vestibular nerve. Now, what are the other things that are important here which we need to know in the internal acoustic meatus? Yes, what we need to know is also along with these is, yes, that the most common site of origin of acoustic neuroma. Yes, the acoustic neuroma, you have heard of it. Yes, if I ask you what is the most common benign tumor of the CP angle, you will immediately tell me, yes, acoustic neuroma. Where is the CP angle? What is the full form of CP angle? Cerebello-pontine angle. Where is the CP angle? Now here we have the petrous temporal bone. This is the middle cranial fossa. This is the posterior cranial fossa. It has an anterior slant and a posterior slant. On the posterior slant, we have the opening of the internal acoustic meatus. We know that. Now here in the center, we have the midbrain, we have the pons, we have the medulla, and we have the cerebellar hemispheres. We already know that. We've seen that. So where is the CP angle? This is the cerebello-pontine angle. Are you getting this? This is what is the cerebello-pontine angle or the CP angle. So the most common site of origin of acoustic neuroma is from the internal acoustic meatus. From which nerve in the internal acoustic meatus? From the inferior vestibular nerve, most commonly. It can arise from superior vestibular also, most commonly from the inferior vestibular nerve in the internal acoustic meatus. It first fills the meatus, and once the meatus is completely filled, now it grows into the CP angle, forming the most common benign tumor of the CP angle. So here we have the base of skull in front of us, and yes, we are seeing this. Here is the petrous temporal bone, this is the posterior slant, anterior slant, and yes, this is the internal acoustic meatus. So where is the CP angle? Yes, this area is what is the CP angle. This is the CP angle. So the most common benign tumor of the CP angle is, yes, the acoustic neuroma, but it does not arise per se from the CP angle. It arises from the internal acoustic meatus. Which nerve from the internal acoustic meatus? We have so many nerves there. Yes, the inferior vestibular nerve most commonly. And now when it goes into the CP angle, answer this, the upper pole of the tumor will involve which cranial nerves? Yes, the 5th and the 6th. Lower pole will involve which cranial nerves? 9th, 10th, 11th cranial nerves. So this is how the internal acoustic meatus actually looks like. Yes, so we have here in the center, we have the Bliss bar. This is the transverse crest. Yes, this is the anterior part, that is the facial nerve. In the posterior part, we have the superior vestibular nerve. And yes, this is the cochlear nerve. This is the inferior vestibular nerve. Along with the small foramen here, we have this is the singular foramen. For which nerve? Singular nerve. So quickly answer these questions for me. Yes, in the internal acoustic meatus, Bliss bar separates which 2 nerves? Yes, yes, facial and superior vestibular. In other words, facial and superior vestibular are separated in the internal acoustic meatus by, very good, the Bliss bar. The singular nerve is a branch of which nerve? Inferior vestibular. Singular nerve supplies what? Posterior semicircular canal. Posterior semicircular canal is involved most commonly in which condition? Yes, BPPV. Very good. The most common site of origin of acoustic neuroma is in the CP angle or in the internal acoustic meatus? In the meatus. From which nerve? Yes, most commonly from the inferior vestibular nerve. So now that we have done the inner ear also. In fact, we have done the whole of the ear. Now you are going to take a walk through the ear with me. Yes? Okay, so are you ready for the walk? Yes, okay. So you are standing at the external acoustic meatus. Are you ready? Okay. So you are going to answer everything that I'm going to ask you. Whatever you're going to see all around, whatever you're seeing all around, that is what I'm going to ask you. Okay, so you're going for the walk. Yes, so you're standing at the external acoustic meatus. What do you see anteriorly? Yes, what are you seeing anteriorly? Yes, you are seeing the tragus. Okay, it is developing from where? Developing from where? Very good, first arch. You will have to answer each and every question. This is for you. This division is for you. Okay. Above the tragus, I am seeing some opening. Some opening. What opening is that? Yes, the preauricular sinus. Why did it develop? It's very good. The fusion defect of first and second arch. Okay, so now, okay, you start walking inside. Okay, you're walking inside. Tell me what you're seeing. What all you're seeing. Where have you reached? What is this? Where is a very hard area or some cartilaginous type? Okay. Okay, cartilage. What are you seeing here? Hair follicles. Okay, hair follicles. Very good. What else? Dirty wax. Okay. And go carefully. Otherwise, is the floor very smooth or something in the floor? Some openings in the floor. Very good. What is that? Santorini. If you go through this opening in the floor, where will you reach? Yes, the base of skull. What soft tissue is that? Yes, the parotid. Very good. Now go more medially. Okay. Okay, you have reached the bony part. How much have you traveled so far? Yes, very good. The 8 millimeters. Okay, now go on going medially. Yes, okay. Where have you reached? Okay, very narrow. Okay, so bend down. What area is that? Isthmus. Very good. So how much more do we have to travel now to reach the tympanic membrane? Yes, the total bony canal is 16 millimeters and the isthmus is at around 5 to 6 millimeters lateral to tympanic membrane. So, okay, you will have to travel that much. Okay, so you have reached the tympanic membrane. Which part of the tympanic membrane will you touch first? The anterior or the posterior part? Anterior or the posterior part? Yes? Very good, the posterior part. Which is more lateral? Posterior part. More accessible? Posterior part. Okay, so you are now in the middle ear. Okay, you have reached the middle ear. What are you seeing posteriorly? What are you seeing posteriorly? Okay, you are seeing that pillar. What pillar is that? Facial nerve, fallopian canal. Which segment is that? Vertical segment. Okay, what else? Chorda tympani. Is it coming inside or going out from here? Okay, it's coming inside. What else? Very good. You are seeing the short pros of incus. What is that area? Fossa incudis. Okay, very good. What else are you seeing? Yeah, okay, you are seeing the facial recess area. Yes. Adytus. Very good. If you go through the adytus, where will you reach? Antrum. Do you want to go? No? Okay, I will push you. I will push you through the adytus. Where have you reached? Antrum, bastard antrum. Now come back. Come back. Let me see how you come back. From where have you come back? Yes? Very good. By making opening in facial recess area. Very good. So you're back in the middle here. Now, do you want to go anteriorly? What are you seeing anteriorly? Eustachian tube. If you go through the eustachian tube, where will you reach? Pharynx, yes, the part of the pharynx behind the nose, nasopharynx. We'll do that in detail, okay. Now go more medially. Go more medially. Where will you reach? Inner ear. So from where on the medial wall will you go into the inner ear? Very good. Which window? Round window. Where have you reached? Okay, scala tympani. Okay, from the secondary tympanic, scala tympani. Okay, now go more medially. Okay, you scala vestibuli. Through the helicotrema. Okay, don't go through this part. Go intracranially. From here, go intracranially. From where will you go? Okay? Okay, cochlear aqueduct. Some other route. Take some other route. Okay, internal acoustic meatus. Very good. Okay. So, you have reached the internal acoustic meatus. In which part of the internal acoustic meatus are you sitting? Superiorly or inferiorly? Where is there more space to accommodate you? Yes, inferiorly. Why inferiorly? Why not superiorly? Superiorly, we have a bar of bone. What is that known as? Bill's bar. So, you are sitting inferiorly. Yes. Have you become acoustic neuroma? Jump from here. Jump from here intracranially. Where have you reached? Yes, the CP angle. What are the nerves going through your head? 5th, 6th. Going through your feet, floor, 9th, 10th, 11th. Very good. So, now come back and now you can go and you can actually take a walk outside. So that completes our ear completely. I hope you have a complete picture of the ear in your mind and you have understood everything thoroughly. Do the MCQs. MCQs make you realize that what all is important and actually what is going to be asked is in which pattern.
Now we have completed very beautifully the anatomy of the external ear, the middle ear and the inner ear. So now let us quickly see in this 3D animation module how the sound from the external ear through the middle ear reaches the inner ear. Now when through the middle ear the sound goes through the footplate of stapes on the oval window, we have seen what happens is that the sound vibrations go through the scala vestibuli and then in the reverse direction the scala tympani and the round window moves out. So this opposite movement creates a shearing action and this shearing action stimulates what is in between the scala vestibuli and the scala tympani. So what is that? Yes, that is the scala media. So this opposite movement vibrates the basilar membrane and on the basilar membrane we have the organ of Corti. So this makes the hair cells of the organ of Corti move, the tip links to open, the potassium to enter into the hair cells and the neurotransmitters to be released and then to be picked up by the auditory nerve to be transmitted through the auditory pathway. So let us quickly have a look at this beautiful model here. So we can see the sound entering into the ear, vibrating the tympanic membrane and through the ossicular chain reaching the oval window. When the footplate moves inside, the round window comes out because of the opposite movement in the scala vestibuli and the tympani. And that creates a shearing action in between in the scala media. So yes, that's the Reissner's membrane, the basilar membrane, and this opposite movement makes the basilar membrane move. And on the basilar membrane is the organ of Corti, where we have the outer and the inner hair cells. The hair cells touching the tectorial membrane, and this movement of the basilar membrane makes the hair cells move against the tectorial membrane. That makes the tip links open, leading to the entry of the potassium into the hair cells, and that in turn opens the voltage gated calcium channels, which leads to release of the neurotransmitter. Yes, the excitatory neurotransmitter glutamate is released and that is picked up by the nerves and it is transmitted through the auditory pathway to the auditory cortex. So that is how we hear.